Good evening, everyone. Here Imran Abbas from Dubai. Again, we are live with another live and real legend, Professor Kamal Mahwar. It is great honor for me to interview Professor. This is reality. I am a follower of Professor now many years. So he's scientist. He's real scientist. So definite. He's a surgeon. And if we see in our life, so I am also surgeon. Unfortunately, we surgeons, we can do good surgeries, but we cannot write paper. We cannot convey our message to other generation. But Professor, yes, he is a best writer. He can convey, and already he proved his abilities and his leadership in this field. So definite, this interview will be little different than others. Definite Professor will share his own experience as well as data about MGB, OAGB. Hope this interview, as already I have received many messages from you, from viewers. So now this is the time, at that time reached. Professor is live with us. And sir, really, it is great honor for me, and you can't believe how much I was excited. So for this time, so now you are live with us, and thanks, sir. Sir, please, over to you, sir.
Good evening, everybody, and good evening to you, Imran. The honor is all mine. Thank you for having me on your program. I know you've had many real legends in the field from around the world on your program. I'm really honored and humbled to be with you tonight. Thank
Sir,
you.
great honor, sir. Sir, as you know, so we have started this series of MGB, OAGB with Professor Robert Rutledge. Now, about 5 months ago, in Jan, we have started this series. What is the target? So, target is to share experience of these legends, practical experience of these legends about MGB, OAGB. Now we are living in this COVID era, so there are some limitations. So this was the best platform to share our knowledge. So we have started this series, and we will continue till June, and we will have a sum-up session, and we will end this series with Professor Karba, who is another legend of OAGB. Sir, because we have some repeated question, because at the end we have this sum up session. First of all, sir, your brief introduction, please, sir.
So, as you know, Imran, my name is Kamal Mahwar. I'm a consultant general and bariatric surgeon at Sunderland Royal Hospital in northeast of England. I'm also a visiting professor at the University of Sunderland. I take some academic interest and I work with some journals, and I'm also working with BOMS and ASGBI and some other societies.
Sir, excellent. So most of our viewers, because most of our viewers are bariatric surgeon, and they are at least interested to bariatric surgery. Definite, they all know you. Just this was the routine question, sir. When and why you have started MGB?
So we started MGB or OGB as you call it in October 2012 in Sunderland with help from Dr. Robert Rutledge. He came over to our unit and he showed us his technique of doing the procedure. By and large, let's say we've stuck to it. We've made that we started it because we were reviewing many club in the unit, and when MGB came up, it looked like a useful option for some of our patients. We started 2019. It was the commonest operation in our unit. So gradually, from the beginnings in 2012, MGB or OAGB, as you call it, is gaining ground in our unit.
Sir, excellent. Sir, as you have mentioned, so now about 1 decade, you are doing MGB, and in my opinion, you are pioneer of MGB in UK. Am I correct?
No, I don't. I'm not a pioneer of anything, Imran. We just picked it up. I think we were probably one of the first units in the National Health Service to be doing it. I am now aware that some colleagues were doing it in private even before we started doing it in Sunderland. So I don't look at myself or in that sense at all. I think we all working to improve outcomes for our patients, and in that journey, MGB has certainly got a role, and I think many surgeons in the UK are now doing it routinely, and it certainly has a role in the British practice.
Sir, in your practice, so which percentage, if we see, so you are also doing sleeve gastrectomy, Roux by mini gastric bypass. If we compare now, so the percentage of procedure, where stands this MGB?
So if you divide our practice, I would say 90% of our practice is primary, 10% is revisional, and of primary there'll be some variation within the consultants in the team as well. But my personal practice would be something like of all the primary procedures, my personal practice would be 60% OAGB, 20% RYGB, 20% sleeve. But it will vary amongst the consultants in the team.
So definite, sir. Now this is a very important for me, especially. I always also I am student of bariatric surgery, and I have learned a lot from people like you. When your practice is 60-70% MGB or OAGB, definitely you are happy. Your patients are happy. The data you have collected all over the world, so results were good. So what is my question now? Because if you remember, also Di Maria has mentioned, and many others, and maybe you were also at initial stages, there were some concerns about MGB like marginal ulcer, bile reflux. So now after the changes of these technical points and also MDT, so still these concerns are there. Or what is your opinion, sir, about this?
So, if you ask my opinion regarding concerns and controversies, because we have published on those aspects, Imran, as you're aware, let's break it down then, because now we're going deeper into the topic. One of the concerns that was raised about this procedure was that this reconstruction for gastric bypass, the loop reconstruction, would be associated with lots of neoplastic changes, cancers of the stomach and the esophagus. So, on that point, we looked at the literature before we started this procedure in our unit, and we were quite satisfied that the loop reconstruction was not associated with, in the historical literature I'm talking about, a higher rate of esophageal or gastric cancer. So, that was the homework we did even before we started that. Then other concerns, or if you like, or the side effects or complications, because there is no bariatric operation yet which does not give any complications or side effects. It's all about having a balance as to where do you think which operation would give patients the maximum better outcome in terms outcomes in terms of weight loss and metabolic efficacy, and still not increase the complication rates too much. That's the balance we're always trying to achieve. So the other major issue with this procedure seemed to be nutritional issues. And to my mind, we have almost cracked it, because we don't have to do a gastric bypass of 200 centimeters or 180 or longer centimeters, because we know from our experience with Roux gastric bypass that the BP limb of 50 centimeters gives you as much weight loss as you get with even longer ones. Same we know from Mason's gastric bypass, which was a loop gastric bypass. He was only doing 60, 70 centimeters BP limb. So I think, doing anything more than 150 centimeters BP limb at this moment in time is probably not needed. I think in future we should even study 100 centimeters BP limb with this, and you will find that the outcomes will not be much different. That's the nutritional aspect of it. We can make sure that we don't get too much of a nutritional issues, too many nutritional issues with this operation. Now coming to the ulcers, I don't think the ulcer rates are any higher than Roux gastric bypass with this procedure. But equally, one thing which is important to understand is that the ulcer rates with both Roux and one anastomosis gastric bypass seem to be inversely linked with the duration of PPI prophylaxis. And PPI prophylaxis is probably safe in this cohort because this cohort is already being supplemented with iron and calcium, and already most of the stomach is bypassed. So you don't really risk suppressing the acid too much. So I give my patients PPI prophylaxis for 5 years at the moment, 30 milligrams lansoprazole, and my belief is that this will reduce the ulcer rates significantly down with both my gastric bypass cohorts, both Roux-en-Y and one anastomosis gastric bypass cohorts. Last but not the least, some patients do suffer from symptomatic gastroesophageal reflux disease, like they do with sleeve gastrectomy, and even some patients with Roux-en-Y gastric bypass have symptoms as well. But then patients are much more likely after OAGB to report gastroesophageal reflux symptoms or nocturnal vomiting, sometimes with choking sensation. What you typically describe as bile reflux, but it's not just bile reflux; it's maybe bile and acid reflux. So I see that approximately 15 to 20% of our patients report that, and in our experience, approximately 1 in 25% patients will then need a conversion to Roux-en-Y configuration in over a period of time. That percentage may change in the future. We don't know that, but at the moment, it seems like a 5% conversion rate. But then at the same time, the internal hernia rates are lower, and also any surgery, revisional surgery, is easier to do because the pouch is much longer, and there are other advantages in terms of the earlier complication rates, because the early 30-day complication rates is known to be lower with OAGB in comparison to RYGB, especially for patients who have BMI more than 50.
Sir, excellent, excellent, and really, this is the definite, very informative and practical information. So during this 1 decade, when you have started OAGE, definite you have changed some steps for better result. There is no doubt, because every surgeon, routine base, you will see the result. And also, so which steps you have changed? A dominant step like length of pouch, this. Definitely, you are already have mentioned the BP limb, and maybe in future you will decrease this BP limb. But what is my question regarding 2 or 3 points that is a very important length of pouch, that tightness of pouch, and also this gastrojejunostomy position size. If sir, you have changed, please.
Yeah, so over the years, what has changed in terms of I've changed a few things with regards to management, but more important, I think your question is with regards to techniques. So I'll focus on that. So
Yeah.
the biggest change that I have made is the BP limb. It used to be 200 centimeters in the beginning in my practice, and then we have taken it down to 150 centimeters approximately 5.5 years ago, and I'm not regretting that change at all. The second thing is it came from a complication. So once I went too close to the greater curvature during my first tapering fire, and I narrowed the outlet of the bypass stomach, and the patient needed to go back to theater for me to then connect the bypass stomach, the proximal bit, which was dilated, to the distal bit. So in a sense, I was too close to the greater curvature with the first firing. So now I'm very cautious with that. That when you do the first firing, you have to leave at least 2 centimeters gap between the black end of the cartridge, where the cartridge will fire to,
Yeah.
and the greater curvature, so that you don't completely occlude the stomach. And the third thing that I think over the years I have noticed with my bypasses, I was in particular because I was trying to get a video for your show, and as we found out, it couldn't work really. My pouches have got slightly narrower, I think, over the years, but again, not too much. Slightly, I now routinely use a 32 French orogastric tube, but then we go a little bit loose on that. So I would say. Generally, they've got slightly narrower than they were before. So these are the three changes I've made with regards to technique, Imran.
Sir, what about this gastrojejunostomy size?
So I have always been doing using a linear 45 millimeter stapler, and then suture closer in 2 layers, and that is still my practice.
Sir, this will be posterior to stapler line. So when we will do gastrojejunostomy, this is the posterior to stapler line.
So the way I fashion my pouch is, the first two firings are 45 millimeters, at the bottom of the pouch, giving it a bit of a U shape, and then I go vertically. So the GJ is constructed at the junction of the first two firings, 45 into 45, and I use the posterior wall of the pouch for the anastomosis.
So then this will be about side to side anastomosis of gastrojejunostomy.
Yes, so if you could say it's going to be functional end to end,
Yeah.
because end to side, if you like, the end of pouch to side of the small bowel, because it's a loop reconstruction, but it would appear to be side to side because that's how it is, but it will be functional end to side.
Sir, are you prefer to fix this gastrojejunostomy to remnant antrum?
No, I don't.
Never do. No need to. Sometime you face twist or something like this.
No, no, I cannot recall when I did it. It's not my routine practice.
Sir, one thing that you have highlighted. So you prefer 150 BP limb. So for all patients, so patient with the BMI 70, patient with BMI
No,
40.
regardless of patient's BMI, metabolic status, sex, race, vegetarian or non-vegetarian, I do not consider any of those patient variables when determining the BP limb. Just like I don't do it for my Roux-en-Y gastric bypasses either. So I think the science is very weak to suggest that we can use different limb lengths for different patients, because there are too many variables, and to study that will take a lifetime. I don't think those studies have been done yet. So my personal bias is to use 150 centimeters for all patients, primary, revisional, all BMIs, irrespective of diabetes or other patient characteristics.
How much, sir, you have? So this weight. So because some patients they don't achieve that weight, that is the target. So have you faced such a situation?
So first of all, I mean, again, we know that there's nothing called a target weight. You're talking about the weight loss response, and I think you're trying to say that some patients don't achieve, significant weight loss that will make a material difference to their quality of life. So that happens with all procedures, as we know that response with bariatric surgery can be unpredictable for some reasons we do not that we don't fully yet understand. Some patients get good outcomes from the same operation, other patients don't. And I think to try and explain that variation in response with limb length, in my view, is a little bit perhaps unscientific, because it is probably not an explanation at all. I was going to say not the only explanation, but I think it's not an explanation at all. We need to understand that cohort. We need to understand why some patients don't lose enough weight with any operation. But I don't think the science will lie in the limb length with regards to OEGB.
Yeah, excellent, sir. Sir, regarding this revisional surgery, if you face a patient after weight regain after sleeve gastrectomy, so same BP limb or no, you will increase the BP limb. Any other criteria?
No, we don't. And again, we stick to same 150 centimeters BP limb. If you see, there's a very elegant study by Professor Chevalier's group there, which they compared the outcomes in revisional setting between 150 and 200 centimeters, and they found no significant difference in weight loss. We have done a similar study for primary cases between 150 and 200 centimeters, and we found no significant difference in weight loss. So we know that between 150 and 200 centimeters, there is no significant difference, and there wasn't going to be. We know that from RYGB data that a BP limb of 50 centimeters is sufficient. We know that from Mason's data of loop gastric bypass. So I think, if anything, if anybody could take away from my talk today, is that if you do 150 centimeters BP limb, you'll be fine. Your nutritional complication rates will be low. And in future, I think we should study 100 centimeters BP limb with OAGB.
Sir, another question. So regarding this, in cases of revisional surgery, you are not interested to measure whole bowel length.
Never, never. I do not measure whole bowel length ever in bariatric surgery. I think it is a mistake to do that. I know that some very skilled surgeons can measure the whole bowel once or twice during the same operation without damaging it. In my hands, that I would struggle to do that. And we are a large training unit. We have nearly 5 trainees every year who come to us. I think it would be very difficult. And to be honest, the science would not support it. Even if I could do it completely, safely, I would still not want to do it because the science doesn't support it. The outcomes of a gastric bypass are not linked to proportion of what we bypass. They're not in proportion to the small bowel length bypassed. The outcomes are delivered irrespective of what you bypass. The very fact that the first 40, 50 centimeters of jejunum and duodenum are bypassed will give you the outcomes in association with a small enough pouch, or I would say, not too large a pouch. So I think that is what we need. We need significant reduction in gastric capacity by giving a small pouch, and we need to bypass the duodenum in the first 50 centimeters of jejunum. That's all we need to do for a gastric bypass, and you'll get the outcomes irrespective of anything else.
Sir, regarding this revisional surgery, so if we go for a weight regain after a sleeve, definite you will resize the pouch.
Generally, no, because but again, we've never been a large sleeve unit in historically even now. So we've not done too many revisional patients in our unit, for the OAGB. So if I was converting from sleeve to OAGB, I would generally leave the sleeve intact, and I would just create a long pouch like you would do with just transect the sleeve, and then just do an OAGB with 150 centimeters. I would not be interfering too much with the sleeve unless there was a documented large fundus left behind or something like that.
So why I'm asking, sir, this because if we see in your primary procedure, so your primary procedure is like Carbaho, about 60-70% like Carbaho. So this is a restrictive with less malabsorptive. So Carbaho is little aggressive, also very so because his pouch is very tight. Also, his anastomosis is also not much wide, also 3 centimeter about, but the BP limb is lengthy. I don't know because he's living in Spain, and I don't know his patients are using more protein. I have no idea. Overall, he's also scientist. So why I am asking in redo surgery, when we face in redo surgery, definite this pouch is little wide than you expect for a initial surgery. And you know better than me, if we do any type of redo surgery, response will be less than primary surgery. Due to this, why I'm asking about BP limb. I don't know because this is a question, common question. So in your limit, as you have mentioned, so in your center, so you have limited procedures of redo. In those cases, you achieved good results.
So, first of all, Imran, whatever the science behind the mechanism of action of gastric bypass or one anastomosis gastric bypass is, it should work for both primary and revisional setting. I cannot understand why the same procedure would need to be completely different in revisional setting. Secondly, with regards to restriction and malabsorption and power and all that, I don't really understand that language. I think we don't fully understand how gastric bypass works, but restriction and malabsorption are not the mechanisms that we need to focus on. I think something happens when we decrease the stomach capacity significantly, and then we bypass the first sections of small bowel, as I said, duodenum and the first 50 centimeters of jejunum. And what happens is not fully understood. Otherwise, you would have a tablet to replicate that effect by now. Coming to primary versus revisional, do we see good outcomes? We see satisfactory outcomes. We see better outcomes than we used to see with conversion to Roux-en-Y gastric bypass, because that does not give much weight loss at all. So, as I said, Professor Chevalier has compared 150 centimeters versus 200 centimeters, and he found no difference. So my suspicion would be that whatever the outcomes you're getting, you will get that regardless of whatever limb length you use. And to be able to do a randomized controlled trial of two limb lengths for revisional setting will almost be impossible without an international collaboration, which is probably not going to happen. So I think we'll have to do what we feel is we are most comfortable with, and our practice is to do 150 centimeters revisional surgery for revisional bypasses.
Sir, excellent. Sir, another thing, so that is the also main concern always is GERD. So you know better than me. So GERD is also not limited definition. It's this word GERD is very wide. So, but what is my question? If a patient with symptomatic reflux, there is a symptoms and also documented, yes, you find. So you are endoscopist or yourself, yes, there is a symptomatic and also documented reflux. Are you prefer MGB in such a case? Have you any experience?
Yes, we do. So when we started off, we were not performing OAGB in patients who had any reflux or hiatus hernia. But
Yeah.
over the years, I've kind of done it for all patients, and the learning I have there is that hiatus hernia makes no difference. So if patient has hiatus hernia, because we do endoscopies for all our patients, it probably does not change the outcomes of symptomatic GORD postoperatively too much. But if a patient is already taking PPI before surgery, I think those patients I would not prefer to do OAGB now, because those patients, the conversion to Roux-en-Y configuration is much higher. It's around 30-40%. It's a very small number, but then we've studied that, and my current feeling is that hiatus hernia, we can do OAGB without any problem. But people who are needing daily medications and PPI even before surgery, I think for them probably a Roux-en-Y gastric bypass, if you can do that, is better. Having said that, BMI 50 plus patients, because Roux-en-Y can be challenging, and also there are other issues. Even those patients sometimes, and especially for BMI 60 plus, sometimes we would just do OAGB and counsel them that they may well need a conversion to Roux-en-Y configuration later. And that is in those cases we are doing it because OAGB is safer to do rather than doing it because we know that the reflux outcomes are great, because they're not. Does it make sense? I don't know if I'm able to explain that clearly or not.
Sir, excellent. Sir, a patient with hiatal hernia. So, if hiatal hernia is 5 centimeter and you are going to do MGB, are you do chloroplasty?
So generally, I tend not to interfere with hiatus at all, Imran. So whichever operation I am doing, I do not like interfering with hiatus. So generally, we would leave hiatus untouched almost. We would rarely do anything with it. But if it is really large and if there's a gaping defect, then maybe we might do some chloroplasty. But again, it's not my standard practice, and it would be less than 1%. I would say would end up doing chloroplasty.
Sir, a case because maybe you have faced in UK. So, after this bending, gastric bending, so when you remove gastric bending, already due to gastric bending, there is hiatal failure, and also maybe there is a large pouch. Have you any experience to change this gastric bending to MGB?
Yeah, we've done quite a few gastric band to OAGB. In fact, it is becoming now the almost the preferred operation for conversion of gastric bands in our unit. So once again, I'm not sure I recognize hiatal failure, but with that, gastric bands fail for all kinds of reasons, and there are all kinds of patients in that category. Some have slip bands, some have pouches, some have just bands which are there not working. So it varies slightly as to what we do, but then generally the standard approach is just to stay lateral to all the scarring and make a long enough pouch like you would with OAGB, and do a 150 centimeters bypass.
And same session you will go. So you will remove the capsule, and also you will go for MGB.
Yeah, so generally patients are counseled that it may become two stage. So we take the band out, and then we take a call, and if it looks like straightforward, we'll do the bypass in the same sitting. But let's say that sometimes it is really stuck and difficult, and if taking the band out takes me 2 hours, then I will not do it in the same sitting. I will then take the band out and leave it, and then come back 6 weeks later.
Sure, sir. So regarding H pylori, sir, already you have mentioned, so routinely you do pre-op endoscopy for the patients. So are you eradicate routinely
We
H
do.
pylori
Yes,
before
we
surgery?
do. Yes, we do. We routinely screen for H pylori on endoscopy by doing a urease test, and then we routinely eradicate it if it is positive.
Sir, in your practice, so have you faced intractable GERD after MGB?
Yes, many
What
times.
you what you did in such a case? So if there is no response to medical therapy, no response to conservative therapy, what was your
So as you pointed out, the first thing is to escalation of medical management and understanding what's causing it. And if medical management has failed, then generally I would request an endoscopy and a barium study to understand the anatomy and what's going on. So generally, by this point, you have decided the patient is going to need further surgery. The only thing you're trying to also ascertain is that is the gastrogenostomy functioning okay or not, or because sometimes you may have narrowing of the GJ, there may be an ulcer at the GJ as well. So if everything is all right, then you can do a simple Roux-en-Y configuration. So which means that you leave the GJ intact, you do another anastomosis between the small bowel 50-60 centimeters down below the GJ, and you divide like the omega loop way of doing Roux-en-Y gastric bypass. But in some patients, if the GJ is narrowed and if there's a problem with GJ as well, then you also have to resect the GJ. And in some patients where we see a large acid reflux as well on the pH studies, because then I would also resect the GJ in those cases and also shorten the pouch.
and they will change to Roux-en-Y gastric bypass.
I would change to Roux-en-Y configuration in most of these patients, but only in some would I resect the GJ and a little bit of pouch as well, because those patients where there is a problem with the GJ or where there is too much acid reflux.
So now why I am asking, sir, this because if we resize or if we change to again MGB, because then this pouch will be little short, and again there is chance of, because mostly we see this ulcer at jejunum site.
Yeah.
Are you
So,
agree?
so, so we were talking about management of persistent GERD so far.
Yeah.
So, management of ulcers, we would manage them as you would manage. As I said, first of all, prevention of ulcer is much easier than management. So, my advice would be to use longer term PPI prophylaxis. As I said, I use it for 5 years now, and obviously we counsel smokers to not smoke. But if they happen, then we treat them with lansoprazole double dose and 30 milligrams BD and sucralfate 1 gram 6 hourly. And generally, most ulcers will heal because we check endoscopy. We do a check endoscopy for everybody at approximately 3 months after diagnosis. And if they're healed, then we recommend lifelong secondary prevention prophylaxis with lansoprazole 30 milligrams daily. If the ulcer is not healing, then we would recommend continue the same treatment for another 3 months. And if it is still not healing, then we would convert them, and then we would again, this is a problem cohort, and I think as you're rightly pointing out, they are again at a high risk of developing ulcers at the new anastomosis as well. Whatever you do, if you do a Roux-en-Y configuration, which is what we will end up doing, then they can develop an ulcer there as well. But my feeling is once you do the conversion to Roux-en-Y, then leave the patient on PPI forever. Don't take it off, and I think that will reduce the rate of problems. And generally, they also tend to be smokers, so that is where you are in a difficult fix. You can try and reverse, but most patients would not agree to a reversal either. These patients are difficult to manage.
Sir, are you agree in such a case? Patient is smoker, yes, they lie sometime. Yes, they ask, yes, I will not smoke. I had this patient. Personally, I faced such a, and still I am facing this situation. So, what is my question? So, can we change such a case to sleep gastrectomy?
Of course you can, but I have never done it. I have never done it, and it will be technically interesting and demanding to do. My personal recommendation would be that if somebody is so adamant on smoking, then I wouldn't bother to convert them to a different operation. I would just want to reverse them. Reversing an OEGB is not that difficult, as we know. So my personal advice would generally be to go for reversal rather than for some further technical, technically challenging operation, and then further risks of complications. So patients had one chance to turn their life around, and if they don't want to take that chance, that's fine. I'm happy to reverse them, but that's all I can do. I wouldn't do a second operation on them.
Sir, excellent. Sir, another question. So maybe you have experience about vagotomy. What is your opinion in such a case?
I do not have any experience of vagotomy. I remember doing some vagotomies as a very young surgeon in India, late 90s. I've seen a couple, but I have, as a consultant, I've never done any vagotomy in any patient.
Because sir, before PPI, you know better than me. So this was the commonest surgery. So this enterectomy and this partial gastrectomy, maybe vagotomy, selective vagotomy, highly selective vagotomy. At that time, it was in market, and we did a lot. I remember in early, it's after this 2000, 2001, 2002. So you are more senior than me. So that time, so this was highly selective vagotomy. So, can we think about this in such a cases?
Imran, I only look old. I'm not that old, so I do not remember a time before PPIs. Actually, to be honest, no, I'm just joking. Look, these things we've all seen them, but then over the last 20 years, I cannot recall any vagotomy. So I think vagotomy has no place in my current practice. It is a historical procedure that was developed when there were no PPIs. I think no current surgeon should ever need to do a vagotomy.
Sure, sir. Sir, regarding malnutrition, because you are a tertiary center, so not only your patients, maybe so patients, so you receive referred patient. Have you received such a malnourished patient after MGB, and what you did?
So we haven't from other unit because we are one of the biggest centers in northeast of England, and centers around us they don't do a large volume of OEGB. And to be honest, even if they were, they are perfectly capable of managing their own complications. They wouldn't be sending their patients to us. But I have advised patients, I've advised colleagues around the world when they've seen patients with malnutrition, and they can be quite difficult to manage. They can be very, very difficult to manage, and you almost have to have a tailored approach to each one of them. And my first advice would be to understand what the patient is and what patient has had. What surgery has been done, what limb lengths have been used, and then where is the patient at, what is the albumin level, what is the weight, and what is bowel frequency. It almost has to be tailored to the patient and have a low threshold for further surgery, but before that build the patient up, because building up a patient does not have to have any surgery at all. We can build up the patient without doing any further surgery, because that surgery would have to be done carefully, and it can be risky. So that's my advice. If you haven't managed patients like this, maybe speak to somebody who's and who understands this operation. These patients will not give you much time, and they can deteriorate very, very, very quickly. So that's my only recommendation, that if you have a problem like this, then maybe call up a friend who may be more experienced in this.
So regarding this micronutrient deficiency, so in your series, in your experience, because we have now a lot of youngsters viewers, so definitely it will be a message from your side. So which micronutrient is the most common deficiency if we face in after MGB?
So, micronutrient deficiencies, Imran, as we can imagine, they depend on the prophylactic, dosages that we use. So, when we started OEGB in our practice, we started using the same protocol for supplementation that we were using for Roux-en-Y gastric bypass patients, and we now find that our pathway, our supplementation dosages are inadequate for both Roux-en-Y and one anastomosis gastric bypass patients, and we are reviewing them, and we're going to alter our iron as well as vitamin D and calcium dosages of supplementation. So my advice would generally be that if colleagues were to look at the ASMBS guidelines for gastric bypass and use that to supplement their patients, that would be the first starting point, and then keep an eye on their results. In our practice, as I said, we had a relatively high incidence of iron deficiency anemia and secondary hyperparathyroidism. So we are altering our pathways. So these patients, the two commonest things that we see are iron deficiency anemia and secondary hyperparathyroidism. So we have to be very careful about supplementing iron and calcium. With regards to other micronutrients, a simple multivitamin is usually sufficient, but we need to make sure that it has adequate amounts of at least 2 milligrams of copper, 30 milligrams of zinc, and all the other micronutrients that these patients would need. So I think if the supplementation dosages are taken care of, and if proper dosages are given, then all these micronutrient deficiencies, the incidence of these can be reduced.
So, sir, for this supplements, because already you have mentioned your protocol of PPI, but for supplements, so for long life, you prefer supplements for your patients?
Yes, for the rest of their life, they need it. As soon as we decide to bypass the duodenum and the first parts of small bowel, they are not going to be able to absorb iron and calcium effectively, and many other micronutrients. So I think it is a myth that these patients don't need supplement. That will lead to problems. My advice would be supplement them like you would supplement Roux-en-Y gastric bypass. Follow the SMBS guidelines, and then keep an eye on them, because if you find that your patients need more supplements or less supplements, then you can tailor it accordingly. But generally, I think at least what patients who are taking patients generally, at least what you're recommending for your patients who've had a Roux-en-Y gastric bypass, if not more. These patients need more supplements, not less.
Yeah, definite, sir. Sir, this regarding dumping. So, have you faced dumping after? Definite, you faced dumping.
Yes, we have, but it appears to be less common after one anastomosis gastric bypass. So I think it appears to be more common in our practice, in Roux-en-Y gastric bypass patients, and it seems to be less difficult to manage with one anastomosis gastric bypass as well. That's just my impression. We haven't formally studied it yet.
Yeah. So regarding nizidoblastosis, because I have faced some cases after duodenal switch or BPD when there is a so BP limb was very long and lengthy, and also we had common channel only 150 something like this. But what is your experience after MGB? Because in MGB you have a sufficient common channel and only 150. So have you faced again nizidoblastosis?
So again, I think in terms of mechanism of action of dumping syndrome or reactive hypoglycemia, as you know, blastocysts, those theories have been challenged for a long time, and I'm not a proponent of them, and I'm not a believer either. I think this is just a simple biochemical reaction. It's got nothing to do with alteration, structural changes in pancreas itself, and those theories have been disputed, stroke condemned for a long time.
Yeah, okay, sir. Sir, regarding this hyperparathyroidism that already you have mentioned, and really it is a challenge, and I have faced one pathologic fracture in a young girl. after this surgery because unfortunately they don't follow properly. So, what is your opinion in adolescents MGB? So, a young girl, so now 16, 17 years old, so she's still young. Also, you know better than me, in ladies, we face more iron deficiency. And are you agree to do MGB in adolescents?
Now, we don't have an experience of doing any bariatric surgery in adolescents, but equally, I think if we were to start, one thing that adolescents will need an operation which can give them durable outcomes over a long period of time. So if the BMI is around, up to 40 45, I think a sleeve gastrectomy would be a good enough operation, and it will give them sufficient mileage from bariatric surgery. But if you're talking about an individual with a BMI of 50 or 60, we know that a sleeve gastrectomy won't be sufficient for them. You do something at 16 17, then you'll end up doing a duodenal switch at the age of 20 or 22. So for those patients, I think I would recommend, as I said, recommend because I don't have any experience of this. I would recommend an OGB, but obviously, with any patient cohort, you have to supplement them adequately, and they have to be counseled. Adolescents can be a difficult cohort, and they need to understand this. Their parents need to understand this. That if they don't take supplements, then there are problems. Gastric bypass and any bariatric surgery, it cannot be done on patients who would not take their supplements. It's just impossible. Even after sleeve gastrectomy, though the rate of micronutrient deficiencies is lower after sleeve, it's not zero. And if a youngster or a patient would not take supplements, then I would simply not do any bariatric surgery on them. This has to be explained to them in detail, clearly, in black and white before surgery. Otherwise, surgery is a non-starter in this cohort.
Sir, no, you know better than me. All types of bariatric surgeries, all types. So this is metabolic surgery. There is no doubt. Now in market, so if you can see, so most of the surgeons they have started to advertise diabetic surgery, metabolic surgery, diabetes. So in my opinion, the real pandemic is that we are facing diabetes and obesity. Okay, COVID is now, maybe we will control this within 1 or 2 years, but the real pandemic is diabetes and obesity. So, are you preferred to do MGB in a only for metabolic purposes, only for diabetes with BMI 30, BMI 27? There started someone. Have you any experience?
So in the UK and in our unit, we follow the NICE guidance. NICE guidance allows in patients with diabetes, we can take the BMI down to 30. So if a patient is referred to us in BMI 30 to 35 range as well, and if patient has type 2 diabetes, then we would offer surgery. Yes, we would. And which operation we would do, it depends on many factors. In my personal opinion, if a patient is on insulin already, then I would probably recommend a gastric bypass. I tend to view this diabetes and obesity as a spectrum of disease, and a reserved sleeve gastrectomy for patients who are at the lower spectrum of disease of obesity and diabetes. Whereas at a higher spectrum with higher BMI and diabetes, which is for prolonged durations or requiring insulin, I would prefer to do a gastric bypass, more likely an OAGP. So, but less than BMI 30, I have no experience of it because we are not funded to do that cohort.
Sir, this same patient, so BMI 30. So then this will be standard MGB or no? Then pouch will be little wide and also
No,
this length.
no. As I said, I do not think we know enough to tailor the procedure according to patient characteristics. So it would be the standard procedure. The same procedure I would do for BMI 70, I would do exactly the same procedure for BMI 32 or 30.
And then have you faced in weight loss more or no? They stopped till 25 and then 22 and
So we don't have a huge experience of BMI 30 to 35 cohort, if that's what you're talking about. But off the top of my head, I do not remember excessive weight loss being a problem in this cohort. But again, we wouldn't have a huge series of them. And as we know, even with significant malnutrition and all, it doesn't happen in everybody. It happens in 1 to 2% patients. So you need to do large enough numbers to know the effect of that. I don't think I'm qualified to comment on that, Imran, because we don't have a huge number of those patients.
so regarding age, so age says I know, so 18 to 65 already we have talked about bariatric surgery. If a patient with 65, 65 plus, but healthy patient, are you preferent patient is now BMI 50, 45, 50? So are you will go for MGB in such a case?
Are you talking about patients older than 65?
Yeah, yeah.
Yeah, absolutely. Again, my pathways of patient procedure selection do not take age into account generally. They take BMI into account. They take, as I said, the three things that are taken into account with regards to procedure selection are the reflux disease, the spectrum of that, how bad is that, obesity, how bad is that, and diabetes, how bad is that. And depending on that, I would recommend a procedure. So I would keep all options open for this patient. In terms of the procedure choice, the three operations that I do generally are Roux-en-Y, one anastomosis, and sleeve gastrectomy, and I would discuss the pros and cons of each with this patient, and then accordingly I will do it. Age is not a contraindication in my practice, as long as patient is fit for surgery.
Excellent, sir. Sir, regarding H pylori, so again we will talk about H pylori because routinely we measure H pylori before surgery. Are you also measure H pylori after surgery?
No, we don't. We
Never,
would
never,
always measure it
never
again.
follow.
So if a patient presents with ulcers, and we are doing endoscopy for ulcers, then we would recheck it if patient has got H. pylori or not. But apart from that, we do not routinely check for it.
So this was my question. So regarding this endoscopy surveillance after surgery, what is your protocol?
So we do not carry out any endoscopic surveillance at the moment. I'm seeing some recommendations coming out from respectable societies with regards to that. I'm seeing some data in support of that coming out. I'm not entirely certain about the risk of cancers after any procedure. So I think, in my personal view, routine surveillance endoscopies after bariatric surgery, after any procedure, are not required for diagnosis, early diagnosis of Barrett's or cancers, or even ulcers, if you like. There will be some patients who will have symptoms, and of course, they should have endoscopies. But I'm not totally sold into routine surveillance endoscopies at periodic interval after sleeve gastrectomy or one anastomosis gastric bypass, which is what some guidance is suggesting.
So regarding this, so definite you follow your patients after MGB, and in symptomatic patients, as you have mentioned, so you do endoscopy. What is this percentage of symptomatic patients that you do?
So that is a very difficult question, Iman, because I don't remember having audited it. But our ulcer rates are approximately, I would say, between 3 to 4% after both the gastric bypasses. I would reckon we because we also score patients who come back with persistent reflux symptoms. So I would think we scope around 10 to 15% of our patients in long term have some sort of surveillance endoscopy for various reasons. Yeah, depending on the patient. Usually there will be abdominal pain or significant reflux symptoms if we are considering revisional surgery.
So, sir, what was your finding in this 10 to 15%? Have you find any silent marginal ulcer in such a cases?
No, we don't find that, I mean, obviously, these patients are undergoing investigations because they're symptomatic, so they wouldn't be silent. They're only undergoing tests because they're symptomatic. So again, as I said, our ulcer rate with this we have studied is approximately 4%. I think 3 to 4%. So we do not do endoscopies in asymptomatic patients. So I could not tell you our silent ulcer rates.
Yeah, you cannot mention. Sir, also you have mentioned, so in your just now, so regarding this reflux symptom, persistent reflux symptom after MGB, it mean you did a surgery in a case with reflux, patient was suffering with reflux before surgery, you did surgery, and also these symptoms continue after surgery. I am correct?
So I think that can happen, and that can only happen if we have not taken care of the pathology properly. So what we tend to do in most of our patients, we also do pH studies, and generally my impression is that it shows significant acid reflux in quite a large number of these patients as well. So then, if you simply do a Roux-en-Y configuration, and like, let's say you do a 50 centimeters rule limb and you do the JJ, and then you divide the omega loop, and you've still left the pouch as a large, long, OAGB pouch, the patient will continue to have significant acid reflux from there. So my feeling is that is why it is important to do pH studies before you convert them. And if patient has significant acid reflux on pH studies before the conversion surgery, then I would also resect the GJ and trim the pouch down and make the pouch shorter. That will reduce acid reflux. So that would be one way to reduce persistent reflux even after you've converted to Roux-en-Y configuration. This happens, Imran, and I have learned from that. I've got a patient who still had some symptoms, not to the same extent, but some symptoms. I think this is what I learned from that patient. that you also have to, in some patients, resect the GJ as well.
Sir, have you faced bile reflux after this mini gastro MGB?
So I would put it all in one category, which is gastroesophageal reflux disease symptoms. So when a patient after OEGB, they can have symptoms of GORD, and the rate of these symptoms is much higher than Roux-en-Y gastric bypass, probably lower than sleeve gastrectomy. So these symptoms are similar. Like, they get heartburn, and usually they have vomiting. Some patients complain of nocturnal choking. I just don't understand that. Maybe, they they, they have a large hiatus hernia or weakness, and the pouch fills up with bile, and it just comes up, and they feel as if they're going to choke. This is something interesting I've only noticed, with OAGB. I've not seen this with sleeve gastrectomy patients who come back with reflux either. So if patients have these symptoms of either significant volume or acid reflux, then I would consider further investigations and treatment. Whether it is bile or acid or volume, it is immaterial to the patient. It is the symptoms that are bothering them, and to be honest, that is what is bothering me. So if a patient has symptoms that are making them unhappy, I would treat them. Whether it's bile or acid or volume, it does not really matter.
So why I am asking this? Because some of surgeons they prefer to do brown anastomosis. So to decrease such a symptoms, so this you are not agree with this.
No, no, not at all. I think a bronze anastomosis in this situation is not likely to resolve your problem. I think it is going to partially address it, but I don't think it will be a solution. I would not recommend it. Most surgeons who do OAGB in patients suffering from significant reflux, they would convert to Roux-en-Y. The only debate is whether you should resect GJ in all or not. That is the only debate. And as I said, I use endoscopy and pH studies to understand that. If endoscopy shows problems with the GJ, if GJ appears twisted at surgery or endoscopy, or if the pH studies show significant acid reflux, then I would resect GJ as well. But I've never done a bronze anastomosis. I think most people have abandoned it now in this setting.
Sir, another question, another this is the debate also, and now because literally I have experience of interviews of many of legends. So, what do you think? What is the main cause of marginal ulcer in MGB?
Imran, if I could answer that question, I think I'll get the next Nobel Prize. So let me allow me to guess with you, because we do not know the answers fully. So my feeling is that obviously it's going to be multifactorial, but one of the key etiopathogenic factors in our patients is that we use staplers. We use staplers to do the anastomosis, and it's a foreign body. So that is the first thing. Whenever you do a gastrogenostomy, there's always a risk of marginal ulcers. But in modern surgery, it has not reduced this complication to a large extent, despite all the advances in everything in PPI, simply because we're now using staplers, and that's a foreign body that irritates it. Other predisposing factors, as you're well aware, this literature is replete with these things. Smoking has been implicated, diabetes has been implicated, hypertension has been implicated. But my feeling is that, you cannot change many of those patient factors, because they are there. Diabetes is there, it will hopefully improve the weight. Hypertension is there. Smoking, if you tell the patient, if they still smoke, you can't do anything about it. What you can do is you can give them PPI prophylaxis for longer, and there is evidence that the ulcer rates are in proportion to are inversely in proportion to the duration of PPI prophylaxis. So as I said, now all my gastric bypass patients get lansoprazole 30 milligrams daily for 5 years. I think that is one single intervention which can reduce our ulcer rates dramatically in these patients, at least for the first few years. By then, the staples are all likely to have been reepithelialized, in my opinion. So that will hopefully reduce the incidence. But apart from that, I don't really know what causes ulcers. I wish I did, Imran, but I don't.
Yeah, thank you, sir. Because if we as discussed many of them, if we one, two, three, so they are top is smoking is at the top, then this foreign body, second one, then ischemia of this side. So no need to dissect because why I am asking this question because we have viewers from all over the world now and many of youngsters. So they are following you, so this will be message for them. So smoker really they are high risk for marginal ulcer, so we must be careful. No need to dissect that for making window and just you will open the window and use staple, because blood supply is very important. And sir, regarding this stapler, are you agree to do hand sewn this gastroesophageal? Can we decrease this part of foreign body at this site?
Okay, so there are two or three interrelated things here. First thing is the vascularity, and obviously, I would completely agree with that. We should disturb as little as possible the vessels on the lesser curvature side. Because that's where the blood supply of the pouch is coming from, and we should be careful really not to dissect too much. And generally, I would tend to leave most of the crow's foot attached as well, because I go distal to that while forming the pouch of the OAGB. Coming to the construction of the anastomosis, we know, of course, we can do hands on and everything, but then the very fact that we are able to do these operations safely is because we do stapled anastomosis. It is not easy to do a hands on anastomosis in somebody with a BMI 60 or 50 or 70. The reason these procedures are extremely safe these days is because we're doing stable anastomosis. Yes, ulcer is a problem, but I would not like to put the cart before the horse. The most important thing is to get the patient home, do the operation safely, and yes, we should try and minimize the rate of ulcers, but I would not recommend it to people to start going to hands-on anastomosis tomorrow, because that will reduce the rate of ulcers. It may well increase the rates of leaks in their hands significantly, and that will kill patient instantaneously. Of course, the leaks are much worse than ulcers. So I think if I have to trade it off, I would any day have a higher ulcer rate and a lower leak rate.
Sir, because now your position is very prime position in this bariatric world, and you can convey. I don't know. Just can you believe? Just now I am thinking this. Before this, I never think about this. So now when we do hernia surgery and incisional hernia and ventral hernia, so now we are using that absorbable taker. Can we think about this absorbable staplers?
Science, never say never to science. Imran, what will happen in the future, we don't know. Will we replace titanium staplers with something that will get absorbed in due course? Yes, I think technology is always surprising us. It is possible, it is not impossible. And we may well have absorb staples in the future that will completely degrade themselves in 3 months time, and I think that will have a material difference to ulcer rates. But until that time, my friend, I would advise that we give longer PPI prophylaxis, and of course, I would not recommend going hands on if that's not how you are trained.
Yeah, because I know you have a good links, and also you can discuss with someone, maybe in future, in near future, so we can replace this titanium. And if we, because this marginal ulcer is really a issue after any type of this anastomosis. So when we do any type of surgery, and definite in till maybe more, maybe after 1 decade, maybe another treatment, I don't know, maybe stem cell, maybe treatment of, I have no idea. But in this era that we are living nowadays, so one of the effective treatment of morbid obesity is surgery. There is no doubt. So maybe with the passage of time, we will go ahead, and this absorbable stapler will replace this titanium. Then maybe we will face less marginal ulcer.
Maybe, Imran, and we have to keep an open mind to that. And again, let's not forget that we are not the only surgeons using staplers to do anastomosis. All GI surgeons use staplers. So stapled anastomosis is a big market. So stapling companies, I'm sure they're looking at all these things as we speak. And who knows what will happen in future. I really hope, like you do, that we have completely absorbable staples in the future, and that will reduce the risk of problems, I think.
Yeah. Sir, what is your dietary protocol after MGB?
So pretty much, I mean, I wish our dietitian, Miss Boyle, and her team were here. Generally, it's the same with all the procedures. So our patients go home the next day, the day after surgery, on pureed diet. So pureed is, like we say, it's not like ground, it's not like mashed, it's like which has gone through a mixer, and it's like it's very slurry in consistency. Then they stay on pureed diet for 4 weeks, and then they gradually introduce normal food. By 3 months to 4 months, most patients are eating, 3 meals off a small plate, having a normalish diet, if you like. We don't generally recommend any protein supplements or anything, but then our patients are not really vegetarians, so generally very few vegetarians. We only recommend protein supplements if there's a problem, like patients having excessive weight loss, or diarrhea, or there's some nutritional issues. So that's our rough dietary protocol. But to be honest, you'll have to ask my dietitian regarding the details of it, Emma.
Yeah, because though this is very important, sir. Now, this message, if someone want to start, so MDT is the crucial. The role of MDT is very important. So then you can handle this such a case with hypoabsorptive or malabsorptive surgery.
As I said again, I don't like to use malabsorption or hyperabsorption, because that is not the mechanism of action of bariatric surgery. Any procedure, malabsorption is always a complication. But you cannot even fathom a bariatric service without a good dietitian, and you must have access to a good endocrinologist, or physician, and psychologist. So I think they don't necessarily have to be in the same room, or same in the same MDT with you, but the MDT should have access to these people, when you need them, because you're going to need psychologists, you're going to need an endocrinologist, and dietitians obviously core members of the team. Without them, the bariatric surgery just cannot happen.
Sir, really excellent. It was, in my opinion, it was a great and very informative interview. Especially, I have learned a lot, especially your position for BP limb. That was very interesting for me, especially for personal for me, and maybe most of our viewers. Now they are, because I think, as I see more than 600, I think they are live and watching us from all over the world. So definite, sir, this your position on BP limb, and from person who is scientist, and in my opinion, and then surgeon. Definite, we have less numbers all over the world. So surgeon with such a research work, it was very informative, sir. Really appreciable, sir. Any message for youngsters who are now going to start MGB?
Thank you, Imran. It's been an honor to be on your program. And I'm truly humbled to be here. Yes, there's a message. Gastric bypass is not a restrictive or malabsorptive operation. The outcomes of gastric bypass are not in proportion to the small bowel length bypass. If you will stick to a 150 centimeter BP limb, your hair will stay black, or whatever color they are, and you'll have a more peaceful life. That's my recommendation. And please try and use PPI prophylaxis liberally. This cohort is already supplemented with iron and calcium. The risks of prolonged PPI are much lower in this cohort compared to other cohorts. So these are my key messages. Thank you for indulging me.
Sir, it is great honor, and also we need your support, sir. We need definitely your support, and we will continue our series. This so next week, this Sunday, this Tuesday, we will have another guest from Egypt, Dr. Abu Zaid Mahmoud Abu Zaid. He is a young surgeon and very energetic, and lot of experience in anastomosis, gastric bypass. And next Thursday, 5th June, we will have live Professor Carbajo, because availability of Professor Carbajo was not available at Tuesday. So we have scheduled his interview next Thursday. So next Tuesday we will have Mahmoud Abu Zaid from Egypt. Then at Thursday we will have Professor Carbajo. Then 13th June, that will be Sunday. So we have scheduled this sum up session, and definite Professor Kamal Mahwar will be the part of that expert panel. And sir, again, so much thanks. We need your support, and it was very great, very informative and practical interview for all of us. So much thanks, sir.
Thank you, Imran. I'm honored. Thank you.
Thanks a lot, sir. Thank you. God bless you.
Bye bye,
Thank you.
Imran. And bye bye, everybody. Good evening. Bye bye.
Thank you. Thank you, sir.